Hello, everyone, and welcome to another episode of Let's Talk Hereditary. Today we have Dr. Matt Khalidi, who's a current Weiss Center chair. Dr. Khalidi, hello.
Hello, Dr. Boss. Thanks for having me.
Well, thanks for being with us. Before we start talking today, we want to talk about Lynch syndrome, but I wanted you to introduce yourself a little bit and tell us a little bit about where you come from and how did you end up here and what is your current role at the Cleveland Clinic?
Sure. As most of my name is Matt Khalidi. I grew up in Allentown, Pennsylvania, and did my medical school and surgical training at Duke. And then from there, I went to do a specialized fellowship in colorectal surgery at the Cleveland Clinic. And since then, I joined the faculty, and I've been here for the last 15 years. And I've been an integral member of the Weiss Center team, which is our hereditary program, under the tutelage and mentorship of Dr. James Church. And then I eventually became the director of the Weiss Center for the last several years now.
Okay. Well, thanks, Dr. Khalidi. We want to talk a little bit today about Lynch syndrome. So do you mind just defining Lynch syndrome to us and tell us why is it called Lynch syndrome and how do we base our diagnosis?
Sure. So Lynch syndrome is a genetic disease or genetic diagnosis, and it's based on a predisposition to getting colorectal cancer and other types of cancers. It's named for Henry Lynch, who was a physician who very much characterized the disease and the syndrome and the risk, and because of that, his name kind of stays with it. It's actually described, it's been around for a long time, or at least noticed for a long time. It's actually described by a pathologist named Alfred Warthen back in 1912, and wrote a paper describing a family who had a extremely high incidence of colorectal and endometrial cancers and some stomach cancers in that family. So he published that paper, and he spent his whole career trying to characterize some of these things. And that kind of was lost for several years, and then Henry Lynch picked this back up in the 1960s, and he reported several different families, including a follow-up of that family with hereditary clustering. And he really brought that to bear, and he talked to his colleagues, and he talked to other people around the country and around the world who started to also notice that they had similar types of families. And then as those groups came together, they just tried to figure out what that is. And it's been a long time, obviously, coming. And it was called Lynch syndrome. It's called Lynch syndrome now. It's been back and forth between Lynch syndrome and what we call HNPCC, or hereditary non-polyposis colorectal cancer. It was called non-polyposis because back at that time, all we really knew of, or people who had hereditary conditions, were polyposis. So people get a lot of polyps throughout the colon. And FAP, or familial adenomatous polyposis, was the big player in that, and that's what people knew and characterized. Then there's also cancers that ran in families that were not polyps or not FAP, and that's how the non-polyposis name came to be. So it's kind of come back and forth, and since it used to be on clinical criteria, basically what the different cancers are in the family and how many people in the family are affected and what's going on. But since we found out what actually causes it, that now is a more precise definition, and it's called Lynch syndrome, again after Henry Lynch. And by definition now, it's a pathogenic variant recognized in your germline for one of the main mismatch repair genes.
Dr. Khalidi, you mentioned the word HNPCC a little bit and Lynch syndrome, and I know when we're reading papers, a lot of times those two words get mixed up together. What is the main difference between HNPCC and Lynch syndrome?
Sure, that's a great question, and I think it's an issue that comes up quite a lot. As I said, Lynch syndrome and HNPCC were previously, even up to 10, 15 years ago, interchanged in the literature and interchanged in any kind of discussions and groups. HNPCC actually all came from, it's a clinical diagnosis, and that all spurred from a meeting of kind of world's experts in 1991 who met in Amsterdam called the Amsterdam criteria. And I always talk about this as kind of the 3-2-1-0 rule. And it's 3 members in a family have to be affected. 2 of them are first-degree relatives of one another. 1 is less than age 50, and the 0 is that FAP is excluded. The people studying the non-polyposis syndromes define these definitions so that the people could figure out how to treat them and kind of make some consensus panels. That was called the Amsterdam criteria in 1991, and that was only colorectal cancer. That group again, or another group got together in Amsterdam in 1999 called Amsterdam 2 criteria, and that included not only colorectal cancers, but also extracolonic cancers, primarily endometrial cancer, urothelial cell cancers, gastric cancer, small bowel, and skin cancers, to name a few. Those are all kind of HNPCC-related cancers. So that was the new definition. So anybody who met Amsterdam criteria was considered to have HNPCC and also considered to have Lynch syndrome at that time. Now, we know that all the people who have or meet Amsterdam criteria aren't necessarily Lynch syndrome, because there are people that fit those characteristics or classifications, but don't, when you do the germline testing, they actually don't have a mutation. We also know that you can have Lynch syndrome, meaning you're carrying a pathogenic mutation, but you don't actually fit those criteria. So those are neither sensitive nor specific, but they're a great guideline to kind of help us recognize who might actually have Lynch syndrome. Now, people with Amsterdam criteria or people who are HNPCC still have a hereditary cancer risk, or still have a cancer risk, but it's not the same as Lynch. And as we're moving more and more towards a knowledge-based field and genetic-based field where we're actually figuring out all the causes of these things, it's important to kind of have a more personalized approach. So people who have a defined genetic mutation or genetic pathogenic variant are Lynch syndrome, and those people are screened and managed very differently than people who are only HNPCC. But you can be HNPCC and also be Lynch, and you can be Lynch without being HNPCC.
We talk a lot about Lynch syndrome, and I know you're in a specialized center where you see those patients almost every day. Is Lynch syndrome that common in the community, and how common is it?
So it's not that common. It's about 1 in 278 people, so just a little under 1 in 300, and that's been looked at from various studies, big population studies or colon cancer broad studies, that when you look at mutations in all those patients, about, like I said, about 1 in 300 will actually have Lynch syndrome. So not very common. We're lucky that we see it a lot here. We're lucky that we can take care of those people because we are a referral center. So we do see it a lot. And the big point of this is that we know that people are at risk for certain types of cancers, and the goal is try to prevent those cancers from happening, or absolutely try to prevent death from colon cancer or death from other cancers. So once we know what they have, we get into a screening program very early.
Okay, and although it's not that very common, but once you identify that 1 out of 278 patients, then you can actually look at their family members and take care of the whole family instead of just taking care of one individual. And you briefly talked a little bit about Amsterdam criteria and mentioned Amsterdam too. How do you diagnose Lynch syndrome starting from the beginning? Like, what are red flags that if a family physician or someone taking care of a random patient that should alert them that this patient might have Lynch syndrome, I should refer him to someone who's specialized?
Sure. So the biggest part to all this stuff, to trying to help people and prevent cancers, is having a high suspicion of these things. The simplest tool we have is not any kind of fancy test or anything else. It's just kind of talking to patients and figuring out a family history. So if people have a family history of colorectal cancer or endometrial cancer, again, even if they meet Amsterdam criteria, great. If they don't, but you have a high suspicion, that's still something that should raise a red flag and kind of think these people may have Lynch syndrome, and they should go and get genetic testing, preferably genetic counseling first, and evaluated for one of the gene tests. The other things we look at are people who develop cancers at a young age. So it's not just colorectal cancer in general, but cancers at a younger age. If people have a couple polyps or polyps that we would not think of as what should be for their age. If we have cumulative polyps, more than 10 over a lifetime, those people get referred for genetic counseling also and get tested. Although lots of polyps is not characteristic of Lynch, it can happen in Lynch syndrome also.
And moving away from Amsterdam criteria and clinical diagnosis, being a colorectal surgeon, there was a couple of years ago, something came up called the Universal Screening Protocol, where you look at all your specimens that are resected. Can you explain that a little bit to us and tell us, how does this lead you to diagnosing Lynch syndrome?
Sure. Again, another great point. We found that if we kind of just looked at clinical suspicion and we relied on the surgeons or the caregivers or whoever to say who should be tested for Lynch, that a lot of things get slipped through the cracks. And we didn't diagnose everybody that could be. We also know that there's a significant amount of people who don't have any kind of family history or don't meet any kind of set criteria who also are have Lynch syndrome, and you don't know it until after it's too late. So several institutions and some guidelines have recommended now universal screening, which is, as you said, for all colon cancers that get diagnosed, they get tested for some of the characteristics on the tumor itself. So there's a biopsy of the tumor or a resected specimen on the tumor, and you can do some different pathology tests to figure out if those things are suspicious for Lynch syndrome. The main thing that we look for is what we call mismatch repair proficiency or deficiency. So we didn't really talk about this, but Lynch syndrome is caused by a mismatch repair gene variant. Mismatch repair genes are essentially the genes that code for proteins that work like spell checkers, is how to say it. When the genetic code gets duplicated and the DNA splits and new molecules get made in new cells, there's a code that has to be matched. And as that code gets reproduced, there are errors that happen. And then these mismatch repair proteins come by, read the code, and decide if an error is made or not. We'll take the bad match out and put the right one back in. So if that doesn't work, or you don't have any good copy of these mismatch repair proteins, these errors will accumulate, and then those cells become abnormal and dysplastic and eventually cancerous. So what we look for on the tumor then is a mismatch repair proficient. And there's two ways to do that. One, you could stain for the actual proteins, something called an immunohistochemical stain, where there's a dye that'll bind actually to those proteins. And then when you look at it under a microscope, it'll light up. So if the protein is present, you'll see a change in the color under the slide, and you can tell it's there. If it's lost, then you know that the mismatch repair protein that you're looking for in particular is gone, and it suggests that you could have Lynch syndrome. Well, I'll talk a little bit more. It doesn't mean you have Lynch syndrome, it's just suggestive of it. The other thing people look for is something called microsatellite instability, which is often synonymous with MMR deficiency. What happens when these proteins, the mutation comes in, or the pathogenic variant comes in, and the code that is made, the length of that code is different. So we look for these areas called microsatellites, where there are multiple areas of repetitive genes. And if a variant is there, the length of that gene or the length of that code is different. And we look at them, you'll see instead of having everything to be that length that's expected, they'll be either longer or shorter. And then that said that this microsatellite unstable. So that's another thing. So if you're either MSI high, microsatellite unstable, or mismatch repair deficient, those are markers that kind of go hand in hand and say you could potentially have Lynch syndrome.
So if I was a patient and I got a pathology report that says I have a microsatellite unstable cancer with immunodeficient for one of the mismatch repair genes, that does not mean I have Lynch syndrome. That's suggestive of it. Is that true or false?
That's true. So there are two main ways that you lose the mismatch repair genes. The one is hereditary, like Lynch, but that's actually pretty rare in the scheme of things. Of all colorectal cancers, about maybe 20 to 30% are microsatellite unstable. And then of all of the ones that are unstable, only about 15 to 20% are actually Lynch syndrome. You can lose your mismatch repair proficiency through methylation events and kind of normal aging, or even sporadic mutations or sporadic tumor mutations in there. So it's still not that common, but it's a red flag again to tell people to get looked at. The other thing is that if you have that information, plus there's a detailed family history, that's a really, really kind of trigger to push you to get those people tested.
One final question about the pathology report. If you had a microsatellite unstable cancer, immunodeficient, and the pathology report says that it was deficient for MLH1, does that always suggest Lynch syndrome, or is there something else that could be suggested from this pathology report?
No, MLH1 is the biggest one that says uncommonly Lynch syndrome. So the most common probably loss that causes MLH1 in general, or MLH1 loss in general, is called epigenetics or methylation, where the promoter region of the gene is methylated, and that methylation actually physically turns off the transcription of that gene. So the protein's not made. Methylation is a normal event. It happens in aging, and particularly on the right side of the colon, it's a little bit more prominent. So you'll have people that lose MLH1 normally through a natural aging process, or cancers that develop with loss of MLH1. And the vast majority of those are actually going to not be Lynch syndrome. The other genes very rarely, if at all, or have any kind of record of methylation. So MLH1 loss in particular is more commonly lost by methylation. The other side of that is if you have MSH2 loss or MSH6 loss, those are almost never lost by methylation, and that's a much bigger target. So yeah, this person probably has Lynch syndrome.
And as a colorectal surgeon, we're talking about screening specimens on colorectal cancer only, but there are multiple other cancers that could be included in Lynch syndrome. Do you mind just telling us what other cancers or what other organs are affected as well?
So the colorectal cancer is the most common, as you said, and that can be about 40 to 60%, even as high as 80% in some series, but that's the highest incidence risk. Endometrial cancer is the second, and that's about 40 to 60%, again, depending on what literature you read. And then after that, there's still a lot of things that happen about 5 to 10% of the time, but those are the two main ones. Then you look at ovarian cancer, look at gastric cancer, small bowel cancers, cancer of the urinary tract, particularly transitional cell cancers, and then you get skin neoplasms as well.
I saw one time a patient in clinic, I think with you, and the patient was labeled as Hereditary syndrome, but they also had a pathogenic variant mutation as well. Do you mind explaining that syndrome to us and tell us, is it different than Lynch syndrome or is it just a name?
So Hereditary is more commonly, I think it's just a name. It used to be considered almost an entirely separate spectrum or disease, but essentially it's someone who has Lynch syndrome, but the particular phenotype or what that patient looks like is they get sebaceous neoplasms, which can be sebaceous adenomas or sebaceous adenocarcinomas. They're essentially tumors of kind of the oil glands in the skin. So people get those in combination of Lynch syndrome and other things. That's been called Hereditary syndrome. They're managed the same way. You just have to be a little bit more cautious and aware and suspicious of anything in the skin as well. And about 10 to 15% of people with Lynch syndrome will have sebaceous neoplasms as part of their thing. So they could be called Hereditary people.
Dr. Khalidi, thank you for your time today. Thank you everyone for being with us. And if you have any questions or concerns, please remember to call us or reach out to one of us, and have a great day.